Imagine this scenario. You've experienced something profoundly unsettling, perhaps a stroke, or maybe a sudden, unexplainable fainting spell.
Right, something that leaves you disoriented, maybe scared.
And you go through, well, every possible test, ECGs, blood pressure checks, those intricate brain scans,
The whole standard workup.
and yet every single result comes back normal.
It's a medical mystery, isn't it? You've had this significant event, but there's no discernible cause. Frustrating.
That frustrating unknown, that kind of hidden culprit, that's exactly what we're aiming to unravel in today's deep dive.
Yeah, it's one of the toughest spots for patients and frankly for us clinicians too. When standard diagnostics just hit a wall.
That leaves a huge gap.
A massive gap in understanding and, crucially, in our ability to prevent what might happen next. Future events, potentially devastating ones.
Exactly. So our mission today is to really unmask cryptogenic stroke. That's the medical term, as you know,
Yeah.
for a stroke where the origin is unknown. And we want to reveal how an incredible piece of technology, the loop recorder, it was really revolutionizing our ability to find those hidden causes. We're zeroing in specifically on a silent heart rhythm problem called atrial fibrillation, or AF.
The hidden AF.
Yes. These tiny devices, they offer this prolonged kind of intimate window into your heart's activity. A window that conventional tests, well, they almost always miss.
And that long-term view is just vital, absolutely vital for prevention.
So for this deep dive, we've looked at some really solid sources.
We have. There's a very detailed academic review on cryptogenic stroke and these loop recorders. It's by Jordi Perez-Redon and colleagues, gives us a great scientific base.
Right.
And then complementing that, we've got a really practical clinical perspective from Dr. Edward Leatham, a consultant cardiologist. He details the real-world use of the implantable loop recorders.
So theory and practice.
Exactly. Together, they paint a pretty complete picture of the challenge and, importantly, the solutions.
Okay, let's dive into this medical mystery then. You mentioned ischemic stroke earlier.
Yeah.
Just briefly, for anyone maybe less familiar, what exactly happens during one?
Sure. An ischemic stroke is, well, it's essentially a brain attack. It happens when blood flow to a part of the brain gets blocked,
Blocks out.
most often by a blood clot. And this blockage, it deprives brain cells of vital oxygen and nutrients. That leads to damage.
And the consequences can be severe.
Absolutely. It's a leading cause of significant long-term disability and, sadly, mortality worldwide.
And when we talk stroke risk, atrial fibrillation AF often comes up. For our listener who might already know AF is a problem, how central is it to this specific mystery of cryptogenic stroke? Is it often the missing piece?
It really is. AF is a huge risk factor. Huge. It increases your stroke risk about fourfold.
4 times, wow.
Yeah. And it's the main player in what we call cardioembolic stroke. That's where a clot forms in the heart and then travels up to the brain.
Okay.
In fact, AF is the source of these heart-formed clots, these emboli, in roughly half of all those cardioembolic strokes.
And why does AF cause clots?
Well, the irregular rhythm in AF means blood can pool and stagnate, particularly in this little pouch in the heart called the left atrial appendage. It just creates the perfect environment for clots to form.
So if AF is such a major known culprit, why are so many strokes still ending up classified as cryptogenic? What does that term really tell us?
Right. Cryptogenic stroke is the official label. It means a cerebrovascular event where the origin just remains unknown, even after you've done a really thorough, exhaustive diagnostic workup.
All the standard tests.
All the standard tests. And it's not a rare thing either. It accounts for a big chunk, maybe 20% to 30% of all ischemic strokes.
20 to 30%, that's a lot of unknowns.
It is.
And the strong suspicion, then, is that a good number of these seemingly unexplained strokes are actually cardioembolic, caused by this hidden or occult, you might hear.
Occult or sometimes paroxysmal AF.
Paroxysmal, meaning it comes and goes.
Exactly. Intermittent.
Right.
So the suspicion is strong that these strokes are actually due to AF that we just didn't catch. It's about connecting those hidden dots.
Precisely. That suspicion is very, very strong because we know AF can be incredibly elusive. So it's highly probable that a good proportion of strokes we label cryptogenic are, in fact, due to AF that just wasn't present during the standard monitoring window.
Which brings us right to the challenge. Why does AF stay hidden so often? Why is it such a master of disguise?
Well, one of the main reasons is that AF can be both asymptomatic and paroxysmal.
Okay, break that down. Asymptomatic.
Asymptomatic means you feel absolutely nothing. No symptoms at all, no palpitations, no shortness of breath, nothing that signals your heart is racing or irregular.
So you wouldn't even know to seek help.
Exactly. And paroxysmal, as we said, means it's self-terminating. It comes, maybe lasts a few hours, maybe a day, and then poof, your heart goes back to a normal rhythm on its own.
So if you're not being monitored right then,
You miss it. It
yeah.
simply goes unnoticed.
And you mentioned this concept of subclinical AF too. Right, that's AF without obvious symptoms, but it still carries that significant stroke risk. And there's another really interesting factor called atrial stunning.
Atrial stunning. What's that?
It's fascinating. Even after the AF stops and the heart rhythm returns to normal, there can be this temporary period where the left atrial appendage, that pouch we mentioned, isn't contracting properly. It's mechanically inactive.
Like it's stunned.
Exactly. Think of the muscle being temporarily stunned. And during the stun period, any clots that might have formed during the AS episode could get ejected into the circulation.
Ah, so the risk doesn't immediately disappear when the rhythm normalizes.
Not at all. This actually helps explain why the highest risk for an embolic stroke after, say, an electrical cardioversion procedure, which shocks the heart back to normal rhythm, is actually around day 2, unless you give anticoagulants beforehand.
Wow.
It shows that lingering danger.
That really highlights the complexity. And it leads us straight into the limitations of the standard monitoring methods we use. Walk us through why these traditional tests often just fail to unmask this hidden AF.
Okay, well, let's start with the most basic. The 12-lead ECG.
The one you get in the doctor's office.
Right. It's a fleeting snapshot, literally seconds long. Its success rate for catching AF, incredibly low, maybe 1% to 5%.
1 to 5%. That's tiny.
It's like trying to catch a specific elusive fish in the ocean by just dipping a tiny net in for 5 seconds. You're almost certainly going to miss it if it's not right there at that exact moment.
Okay, not great for something that comes and goes. What about the next step up, like a Holter monitor?
Yeah.
Maybe wearing it for 24 or 48 hours?
The Holter is definitely an improvement because it's continuous for that time. But the duration, just 24 or 48 hours, is often still nowhere near long enough to catch AF episodes that only happen infrequently.
So its detection rate is still low.
Still quite low, yeah. Around 2.4% in many studies. You might wear it for 2 days, feel perfectly fine, have a normal recording, but you just happen to miss the, say, 1 hour later that week, your heart went into AF.
Right. So we move from days to maybe weeks. Ambulatory telemetry. That can last up to 30 days.
It can, yes. That's definitely a longer window. But even then, the detection rate varies hugely. Some studies show 0%, others up to maybe 25%.
Why such variability?
Well, a big issue here is patient compliance. Wearing monitoring patches and wires for a month, it can be cumbersome. Non-compliance can be pretty high, maybe up to 36% in some reports. People get tired of it. It interferes with life.
That makes sense. Now, there's a case example you mentioned from the sources that really drives this home for me. It's quite compelling. A 65-year-old woman, she had a TIA, a mini stroke.
Yes.
All her standard tests came back completely normal. Doctors suspected AF but couldn't prove it. They recommended anticoagulation, blood thinners.
Which is standard practice in that situation, potentially.
But she, quite reasonably, wanted proof before starting a long-term medication like that. So she opted for an implantable loop recorder, an ILR.
Right. And this story really illustrates the problem perfectly. For 3 years? 3 years. No abnormal rhythms were recorded, not doing routine checks, not through her home monitoring system, nothing.
It looked like a dead end.
It seemed like the device would just be removed with no answers. But then, just before it was due to be taken out, they did one final check. And the results.
What did they find?
She had been in continuous atrial fibrillation for the entire preceding week.
Whole week after 3 years of nothing.
A whole week of silent, hidden AF finally unmasked. It's not just an anecdote, it's a powerful illustration of why short-term monitoring just doesn't cut it for these cases.
Imagine being that patient. 3 years of uncertainty, then boom, the answer.
Yeah.
It just highlights the persistence needed.
It absolutely underscores the paroxysmal, the coming and going, and the often asymptomatic nature of AF. A brief snapshot, even a few days, often isn't enough. You need that long-term surveillance.
So this is exactly where loop recorders are sort of heroes of this story, become so essential. Fundamentally, how do these devices work? How do they achieve this long look?
Okay, so loop recorders continuously monitor the heart's electrical activity. They operate using what's called a looping memory.
Looping memory.
Yeah, it means they're constantly recording, but they only save the data when something triggers them.
What kind of triggers?
It can be automatic based on preset heart rate limits, like if it goes too fast or too slow, or triggered by irregularities in the rhythm, the RR intervals. Some can even detect changes in the P wave, which relates to the atria contracting. That's crucial for catching silent asymptomatic episodes.
And can the patient trigger it?
Yes, patients can also manually activate the recording if they feel symptoms like palpitations or dizziness. But for finding that silent AF, the devices with those automatic detection algorithms are really what you want.
Okay, let's talk about the types. First up, the external loop recorders, ELRs. What are they like? How effective are they?
ELRs are small, non-invasive devices, usually attached to your chest with electrodes. Sometimes it's a wristband setup. They can record for up to 30 days.
Okay, like the ambulatory telemetry, but maybe focused differently?
Sort of. They're often also called event monitors. Their diagnostic success rate for finding AF, well, it varies across studies, but it's generally in the range of 5.7% to maybe 20%.
Better than a Holter, but still maybe missing some.
Potentially, yes. They tend to have high sensitivity, around a 93%, meaning they're good at picking up heart activity changes, but their specificity is lower, maybe around 51%. They can sometimes be fooled by artifacts, electrical noise that looks like an arrhythmia, but isn't.
Got it. Now, the Embrace trial. That was a big one for ELRs, wasn't it?
It was very significant, yes. Embrace was the largest randomized trial looking at ELRs specifically for patients with cryptogenic stroke, or TIA, aged 55 or older.
And what did it show?
It showed pretty decisively that these external loop recorders were superior to the standard 24-hour Holter for finding AF. In the trial, AF was detected in 16.1% of patients using an ELR.
16%, compared to the Holter.
Compared to just 3.2% with the Holter.
Wow, big difference.
Huge difference. And importantly, this led to a much higher rate of anticoagulation therapy being prescribed, 18.6% in the ELR group versus 11.1% in the Holter group. So finding the AF actually changed treatment for a lot more people.
That really does sound like a game changer for that level of monitoring. But the true sort of revelation often seems to be the implantable loop recorder, the ILR. How are these different? What makes them so powerful?
Right. The ILRs take it to another level. They are minimally invasive. We're talking about devices roughly the size of a matchstick.
Tiny.
Very small. They're leadless, and they're inserted just under the skin subcutaneously, usually in the upper left chest area. It's done through a very small incision. They record the ECG signals using internal electrodes.
And the key is their longevity.
Exactly. They offer an incredible long-term view. They last approximately 3 years.
3 years of continuous monitoring.
Pretty much. And the modern ILRs, especially those developed since around 2010, have really sophisticated automatic AF detection algorithms built in. They look for those RR irregularities, P-wave changes we talked about.
Plus, they usually offer wireless home monitoring. Data gets transmitted automatically, often daily, to the cardiology team. And most are now MRI compatible, which is a big practical advantage for patients who might need other scans.
So with all that tech, what's their detection rate like compared to the external ones?
Their diagnostic yield is notably higher. We're talking ranges from 20% up to maybe 36% in different studies.
20 to 36%. That's finding hidden AF in potentially 1 out of 3 or 1 out of 5 patients who had a stroke of unknown cause.
Exactly. It's a true game changer in terms of getting a diagnosis. Now, they typically are set to detect AF episodes lasting longer than about 2 minutes, but even so, their overall sensitivity for detecting any AF is very high, around 96.1%.
In specificity, fewer false alarms.
Good specificity, too, around 85.4%. And crucially, they can accurately quantify the AF burden.
AF burden, what's that?
That's the total amount of time a patient actually spends in atrial fibrillation over that monitoring period.
Yeah.
It's not just if they have AF, but how much. Okay, that seems important for treatment decisions.
It likely is, yes. And the Crystal AF trial really cemented the ILR's position here.
Tell us about Crystal AF. Why was it so pivotal?
Crystal AF is key because it's the only randomized study that directly compared implantable loop recorders to conventional monitoring, like Holter, ECGs, in patients who had had a cryptogenic stroke.
And the results?
The results were dramatic, really dramatic. At 6 months, AF was detected in 8.9% of the group who got the ILR versus only 1.4% in the control group using standard methods.
8.9 versus 1.4. Okay.
By 12 months, it was 12.4% with the ILR versus just 2.0% in the control group.
That was a huge gap.
And then at 36 months, the full 3 years, it was an astounding 30% in the ILR group compared to only 3% in the control group.
30% versus 3%? That's a tenfold difference over 3 years.
It is. It's not just a small improvement. It's the difference between missing almost all the cases and actually catching a diagnosis that could save a life, prevent another stroke.
And were these symptomatic episodes?
That's another crucial point. In the Crystal AF trial, 79%, almost 4 out of 5 of the AF episodes detected at the 12-month mark were completely asymptomatic, silent.
Wow. So people had no idea.
No idea at all. And, as expected, the ILRs led to much higher rates of anticoagulation use, 14.7% versus 6.0% at 12 months. It showed how finding the AF really changed treatment. Now, interestingly, this study didn't actually find a statistically significant difference in the rate of recurrent strokes, or TIAs, between the two groups.
Huh. So finding it didn't necessarily stop the next stroke in that trial.
Not with statistical significance in that particular study, but the diagnostic power, the ability to find the hidden AF, was just undeniable. And getting the right diagnosis is the first step.
Absolutely. Now, beyond stroke, these ILRs, they're also incredibly valuable, you mentioned, in investigating syncope. That's the medical term for fainting, right?
Yeah.
Sudden, brief loss of consciousness.
Yes, exactly. Fainting spells. ILRs are equally valuable here, particularly for what we call unexplained syncope.
When you faint and they can't figure out why.
Precisely. Syncope can be caused by a whole range of heart rhythm issues. Things like sinus node dysfunction, where the heart's natural pacemaker isn't working right, or high-grade AV block, where the electrical signals between the heart's chambers get interrupted.
Serious stuff.
Can be. Or even more dangerous arrhythmias like ventricular tachycardia or fibrillation. The beauty of the ILR is its ability to capture these potentially rare, fleeting events. The kind that happen maybe once every few months when symptoms are infrequent and short-term monitors just aren't worn long enough to catch them.
So it solves the "it never happens when I'm wearing the monitor" problem.
Exactly that problem.
And there are broader implications too, right? Things like health economics, even driving restrictions.
Absolutely. From a health economic standpoint, think about it. Putting in an ILR after the initial tests for syncope are inconclusive is often much more cost-effective than having someone repeatedly admitted to the hospital for unexplained fainting spells.
Avoids that whole diagnostic merry-go-round.
Completely.
Oh.
And regarding driving restrictions, if someone has unexplained blackouts, they might face driving bans. Getting a confirmed diagnosis with an ILR allows for a much more precise risk assessment. It might confirm a condition needing treatment, or sometimes even rule out a dangerous heart rhythm, potentially allowing driving privileges back sooner. It gives clarity.
So for our listener then, when might an ILR typically be considered? What are the main situations?
Well, the key indications would be unexplained syncope, where standard tests haven't found the cause, cryptogenic stroke, TIA, or even something called transient global amnesia, where AF is strongly suspected but hasn't been proven.
Okay.
Also, for infrequent but concerning palpitations that shorter monitoring hasn't managed to catch, or if there's a suspicion of intermittent AV block or those long sinus pauses we mentioned. Basically, when you suspect an infrequent but significant heart rhythm problem is the culprit.
And just to summarize, what are the core benefits of these implantable devices?
The primary benefits really are their unparalleled ability to capture very rare, infrequent arrhythmias over a long period. Their high diagnostic yield, they find answers much more often. The fact that the implantation procedure itself is minimally invasive.
Right.
And maybe most importantly, the increased confidence they provide. Confidence for the clinician in the diagnosis and confidence for the patient in the treatment plan. It's about getting concrete answers.
But, like any medical tool, they're not perfect.
Yeah.
There must be limitations or downsides.
No device is perfect, you're right. There are small risks associated with the implantation, maybe a small chance of infection at the site, or the device shifting slightly, device displacement.
Okay.
There's also the potential, though less common with newer devices, for false positives. That could be from electrical noise or what we call oversensing of other muscle activity that the device misinterprets as a heart rhythm problem. The algorithms are much better now at filtering this out, though. They do have a limited memory capacity. It's a loop, so eventually the oldest data gets overwritten to make space for new recordings. And, of course, there's the initial cost of the device and the procedure.
So considering those points, who benefits most from an ILR? Is it for everyone who's had an unexplained stroke or faint?
No, definitely not for everyone. They're best indicated for patients who are most likely to have that hidden paroxysmal AF, and this is key, who would definitely be candidates for anticoagulation therapy if AF were found.
Okay, so you need to identify those high-risk individuals. How do you do that?
There are several risk factors we look for that increase the likelihood of finding AF and the need for treatment. Things like older age, a history of coronary artery disease, having high scores on risk calculators like HH2 or CHA2DS2 VAST.
Those calculators that weigh different risk factors.
Exactly. They factor in age, hypertension, diabetes, history of stroke, vascular disease, heart failure. It gives a score predicting stroke risk in AF. Other indicators might include having had a particularly severe initial stroke, having frequent extra heartbeats called premature atrial complexes, signs of left atrial enlargement on imaging, or specific patterns on brain scans that look like they came from heart emboli.
So it's about targeting the technology to those most likely to have the problem and benefit from finding it.
Precisely. Targeted investigation.
Which brings us to the real so what behind all this tech and research. It's ultimately about preventing that next stroke, isn't it? Stopping that silent threat before it strikes again.
That is absolutely the goal. The whole point of detecting this subclinical hidden AF is to prevent future strokes. Once AF is confirmed, we know that for most patients at significant risk, starting anticoagulation therapy dramatically reduces the chance of clots forming and causing another stroke. And these long-term monitors, especially the ILRs, they can, as we saw, double or even triple the AF detection rates compared to standard methods in these cryptogenic stroke patients. It's proactive prevention of a potentially devastating event. That's incredibly powerful.
It really is. It's amazing how far the technology has come. But, like all good science, discovering answers often leads to more questions. There are still things we don't fully understand, areas for future research.
Oh, absolutely. Several critical questions remain. For instance, when we find AF with these long-term monitors, especially if the episodes are very brief, is that newly discovered AF always the direct cause of the stroke the person already had? That link isn't always perfectly clear.
Interesting. What else?
There's the question of cost effectiveness in all scenarios. We mentioned one study suggesting even a week of monitoring might be cost effective after stroke, but we need more research on the value of these much longer monitoring periods, like 3 years with an ILR, across different patient groups.
Okay. Are researchers looking for easier ways to predict who might have AF? Like biomarkers?
Yes, definitely. There's a lot of interest in finding specific biomarkers or maybe surrogate markers that could help predict who's likely harboring hidden AF. Things like levels of certain proteins in the blood, like N-terminal probrain natriuretic peptide, a level above 265.5 pgml has been suggested as a potential indicator. Or maybe subtle changes in how the left atrium functions, like decreased left atrial strain measured on echocardiograms.
So finding clues without needing the long-term monitor, maybe.
Potentially, or at least helping select who needs the monitor most. And another really big question is about treatment. We know anticoagulation works well for AF found conventionally. Does it provide the same level of benefit when AF is found only through prolonged monitoring, especially if the total amount of the AF burden is quite low?
Does the amount of AF matter for treatment effectiveness?
That's the question. Does the magnitude of benefit depend on the AF burden? We don't fully know yet, and we're still refining the optimal timing, duration, setting even the specific type of device for cardiac monitoring in these complex cases. Lots still to learn.
This has been such an illuminating deep dive. So let's kind of recap the main takeaway. Loop recording monitoring, whether external for shorter periods or implantable for the long haul, really seems like a superior diagnostic strategy compared to the old conventional methods, especially for patients with cryptogenic stroke or TIA who are good candidates for anticoagulation if AF is found.
It absolutely is. It's an investment, yes, but one that often far outweighs the potential costs, both financial and human, of preventing future strokes and reducing hospital readmissions.
It feels like it's about empowering patients and doctors with information that was just out of reach before.
Turning those frustrating medical mysteries into hopefully solvable problems with clear treatment paths. That's the goal.
And as you, our listener, reflect on this, maybe consider this. An implantable loop recorder isn't just a piece of tech. It's really a profound window, isn't it? A window into the heart's hidden behavior over months, even years. It offers perhaps the best chance we currently have of catching those rare, silent, but potentially very dangerous arrhythmias before they cause significant harm. Think about how powerful that is, the ability to uncover the unseen, especially when it comes to safeguarding something as precious as your brain and your future.